Have you ever wondered what's in our blood? What it can tell about our well-being? What about the innovative technology used to unravel the mystery of what's in our blood? Hello, I'm Dean Whiting, and this is It's in Our Blood, the podcast series that explores the critical role technology plays in the pathology laboratory, in hospitals, and in the community setting. So in this episode of It's in Our Blood, we're talking about a men's health topic, and that is prostate cancer. We're very, very fortunate today to have Dr. Ken Sikaris with us. He's the Associate Professor at the Department of Pathology at Melbourne Uni and Director of Pathology at Chemical Pathology at Melbourne PATH, where, interestingly, well over 1,000 men are tested per day for some form of prostate investigation. So welcome, Ken, and thank you very much for joining.
Thanks, Dean. Nice to speak to you about this topic.
Yeah. So Ken, I guess the first thing is a scene setter. How important is prostate cancer in the current healthcare environment?
Well, a bit like you said, it's one of the most common immunoassays that we have in the laboratory, only second to thyroid testing really, and vitamin D is a very common concern, but it's one of the main concerns in the immunoassay area of the lab. So it's like 10 or 15% of all the work we get is related to prostate cancer. That's apart from the fact that it's the most common cancer diagnosed in men, and in the top 3 of cancerous killers of men. So it is a major issue for labs and for the health system in general.
Yes, I can see it's very a big issue. Having reached that age, I've been to my GP and I've had the various tests done, and typically it's a blood-based prostatic specific antigen that's done. Yeah. What reliance do we still have on, say, a blood-based PSA for diagnosing prostate cancer? It's one of the only blood-based screening tests for cancer that we have, and it started over 20 years ago, and things haven't changed. We haven't found a better way of screening for this common cancer. Imagine you might be able to test urine or semen or imaging and people have certainly tried to do that, but nothing's improved on what PSA has done, and PSA itself has improved over the years as well. So it's sort of upped the ante in terms of what capabilities we have. But it's another thing that's changed over the last 20 or 30 years. Men are living longer and retiring at the same or an earlier age and living longer, so they are concerned about their health in the long term. And whilst it's true that many men will die with their prostate cancer rather than from their prostate cancer, it's still a concern for men who don't want to die of prostate cancer and don't want to die of some other things but still suffer with their prostate cancer. So it is a general concern, and the longer these men are aware of their prostate cancer, their relatives are aware, their friends are aware, the awareness of prostate cancer doesn't need much media to keep it close to the mind of all older men. Okay. Yes, I know amongst my group of friends, but amongst my group there are at least 2 or 3 people suffering in one way or another from a disorder of the prostate. Yeah. So we screen with a prostate specific antigen. So that's a technology using an immunoassay. We diagnose with anatomical pathology. So we image the cells, the cancer cells themselves.
The improvements in the PSA test included, we really understand, each company has made this progress in understanding the various forms of PSA in the blood. And so every company's improved that understanding, their ability to calibrate, the ability to get consistent results, and so that's improved the reliability of the PSA test. Something that has changed recently is the imaging of the prostate with MRI. So that in the past, if you had a raised PSA, a warning level of PSA, people, well, frankly, that you just get lots of needles into the prostate and hope that one of them finds the cause of that raised PSA. Whereas now you can image the prostate and target the areas that look like they might have prostate cancer rather than this random sampling, and that's far more effective at picking up those cancers. And not only that, but in the biopsy, in the past it was a transrectal biopsy, which was the most common form, and that had a small risk of infection, but can be quite a serious infection. Whereas now the MRI-guided needle biopsies through perineal biopsy have very little risk of infection and are better targeted. So all of that's improved. And then we get into the biopsy level. Once we've got that bit of tissue that's suspect, even that's progressed over the years to a clearer understanding of what type of changes are aggressive and which aren't. And it's a bit unfortunate because we had this scoring system, the Gleason scoring system, which grades things out of 10, and to some men have a score 5 out of 10 prostate cancer might seem disastrous, like you've got prostate cancer and it's almost a pass mark for what? But a 5 out of 10 Gleason 5 prostate cancer is now considered so benign you don't do anything about it, or even 6. And it's only once you get to 7s or 8s that something needs to be done urgently. So the whole the way of suspecting them, finding them, and diagnosing them is continually changing. Nothing keeps still. It's such an important area that everybody's trying to improve on that system.
Yeah, exactly. I mean, with the increasing, I guess, awareness and technology around genomic-based testing, circulating tumour cells, circulating or even gene mutations, are we moving in a direction where technology could say, hey, here's a cohort of people who potentially should be screened more often for prostate cancer? Are we at that stage yet, or are we still a little way to go on that?
We went a little bit down that path maybe 10 or 20 years ago, because we said, well, people with a family history must have a higher predisposition, and so people with a first degree relative, a father or a brother that's had, well, they're high risk, and so we should at least start testing them earlier. The aggressive cancers tend to occur earlier. But it's true that probably every week people are finding new genes that contribute to that risk, rather than just the hearsay of family history, looking at DNA to see what elements of that family history are there that are linked to prostate cancer. And so now there are systems where you can search the whole genome to see all the genes that are related to prostate cancer and try to calculate that risk. It hasn't reached quite the strength of the family history. So if, say, a brother with that history means your risk of getting prostate cancer is twice the general population. Whereas the best genome studies we have mean that you're 50% higher, than the general population. But that's still relevant, because a man who knows that they're at higher risk by 50% has the option of testing earlier and being more rigorous in the way that they do that testing. So I'm sure that the new technology sort of brings challenges to existing protocols, because we didn't have that new technology, and now we have to review the protocols to see how this fits in with our previous ways of thinking. But within a year or two, it'll be fairly common to be able to do a gene test if you're unsure of your family history, or you want to be more sure about your family history.
I think that's the way it's all going. This podcast is brought to you by Pathology Technology Australia, the peak body representing the companies who invent, manufacture, supply and support the vital technology needed for testing those precious patient samples. Did you know that pathology tests provide vital information for about 70% of medical diagnosis and 100% of cancer diagnosis? Pathology Technology Australia, representing the companies who provide the innovative technology so critical to a high quality, affordable and accessible healthcare system. What about somebody who's then had treatment for prostate cancer? What's the role of the technology there?
Yeah. Again, things are changing. In the past, we used to say if you've had the prostate gland taken out, which is the definitive treatment for prostate cancer, then if your PSA becomes normal again, as if you've got a prostate, well then the cancer must have come back. Whereas now we're sort of saying that no, if you've had the prostate taken out, your levels of PSA must be virtually zero, and any increase in these ultra-sensitive levels means that there may be an early recurrence. The problem is, of the men that have a radical prostatectomy, 1/3 of them have a PSA which is undetectable and nothing happens. 1/3 of them have a PSA which never became undetectable and progresses, which is unfortunate. That's the group we're trying to improve on. And then 1/3 of them have a PSA which is undetectable and becomes detectable. Now, what does that mean? Does it mean that they've got an aggressive cancer back? And usually it doesn't. It means that they've got some less malignant cells that have remained behind and won't cause a problem. Well, the quicker we can get that understanding, the more reassurance that man can have about living a normal life and feeling, a sense that their surgery was all worthwhile. So, so that close watching of PSA after treatment, but there's also this other form of treatment which is called active surveillance, which sounds like you do nothing except watch, but it's actually watching very closely. You know that there's something there and you're wondering what it's going to do, so you watch it very closely, and then as soon as there is some evidence that it needs treatment, then immediately you jump on it.
So it's like baselining. So somebody would have a baseline background PSA, then you watch, and any deviation from that baseline might cause you to think maybe we should be doing something.
That's right. And the Medicare schedule, the government urologists Australia are aware of that, and so there's no restriction on once you've had an identifiable risk, you're allowed multiple PSAs in the year to closely monitor that situation. Even that science, we used to talk about the PSA increasing by a certain amount over the velocity, but now, doubling time is probably the better way. It's a technological investment in thinking of the PSA in terms of its exponential rises rather than its linear rises. So all of that is improving. By the way, Cancer Australia, of course, has an interest supported by the Prostate Cancer Foundation of Australia, and they're reviewing as much data as they can to model all of these different ways of detecting and monitoring and treating prostate cancer to see whether there's some machine learning that can be applied to understanding who does well and who doesn't.
Yeah.
And so and that work's happening as we speak as well.
No, that's a topic for a future podcast. Is around machine learning and how the IT can be used.
Yeah.
And we have clearly there's opportunities for the technology, but we also have some limitations in the data we actually have about end-to-end outcomes for people in the healthcare system here. But nevertheless, so who should have a PSA blood test?
Well, the guideline is that every man above the age of 50 should consider whether to have it or not. So certainly every man's entitled to it. It's not an obligation for a GP to bring it up because there's no surety in that testing, and so it's really a personal choice for any man. So ideally, a man would be informed, or if they go to a GP saying, well, what should I do? The GP should say, well, here's some information, go away and think about it and come back and tell me whether you want the test. So that's the paradigm we have, is that there should be an informed consent for all men above the age of 50. Things get a bit more complicated when you start having a strong family history, because then is it really up to you? You know, when you're identified as a high risk, at the moment we're suggesting you should start at an earlier age, 45 or 50, because many men with a family history have cancer which is too late to treat by the age of 55 or 60. Well, you need to detect it 5 or 10 years beforehand, so you need to start at an earlier age. So, once there is a family history, the recommendation is you should think of starting at age 40 or something like 10 years before that relative got theirs. And then the protocols are in place to what you should do once you decide to go forward. But there are complex issues there. I mean, most men are willing to share that story that they've got prostate cancer with their relatives, but is it an obligation to tell all your relatives that you've got the cancer and they should think about testing it as well?
Interesting personal dilemma, isn't it?
Yeah, but certainly for a father who's got a son heading into middle age, you would say that, they should be, and they become biased because they see what their father or their grandfather's going through, and that may be a benign course where the cancer didn't do anything to them and they become very relaxed about it, or may be very biased towards doing something because they've seen how much granddad suffered and they're not going to go through that. So that's why it is a very personal decision for men to kick off all this technology. The technology's there. The hardest part is to kick it off and say, well, I really want to be addressed.
So, Ken, if you had your prospectoscope on, what would you like to see in technology coming in the future for prostate cancer? What would change and how would you use that?
The main issue is trying to decide which prostate cancers are aggressive and are going to kill a man rather than he just lives with it without a consequence. And so whilst we have that ability to look at the rate of change of PSA or look at the Gleason score to see what aggressive elements are there, I think that new technology, particularly DNA technology, will tell us what genetic changes are present in the cancer that mean that it'll grow quickly. And whether that's in a blood test or in a histological in situ stain, that's what we're hoping to find which cancers are the aggressive ones that need treatment. And those changes occur fairly early, so you might be able to really catch all cancers at a very early stage and treat them in a sort of a minimally harmful way. So that's the holy grail, to find which cancers are the most aggressive and be confident about that in terms of who you should treat.
Very good. All right, so just rounding out then, what should men do if they wanted to find out more information about prostate cancer?
Well, we're very lucky in Australia that we've got the Prostate Cancer Foundation in Australia, who have got funding and support to provide education for men who are thinking about prostate cancer testing or are in the process of having their prostate cancer managed. So they've got a terrific website with new resources in most languages, and not only that, but they also support sort of local men's groups, and I've been to many of those, and men who are being managed for prostate cancer, and men who are thinking of being tested for prostate cancer, wives of people go along there and get the information from those men that are learning as they go. So it's really a tremendous opportunity. Of course, a lot of GPs will have the time to discuss and talk about these, but as a minimum, a GP should be able to direct you towards that information, whether it's from the PCFA or otherwise. And there are other men's health groups. As long as you show an interest, you'll find your way to that information.
That's very good. All right, so that's wonderful, Ken, and it's been very illuminating. I wanted to thank you very much for participating in this, and then please look out for future podcasts on men's health topics as we bring them up. Thanks very much for listening, and bye for now. Thank you for listening to this edition of It's in Our Blood. Look out for further topics in this series, or go to pathologytechnology.org.au. This podcast is produced by London Agency, Melbourne, Australia.